Good evening, everybody, dear colleagues. On behalf of Mariana Adamo, I'm going to co-chairing this session together with her. My name is Georg Nickenig. I welcome you warmly to this wonderful session on controversies in atrioventricular valves, the heart-TIM ring, volume number 2. We're going to have case presentations, 4 beautiful cases being presented and then discussed. We are looking at the indications and also at the procedural specification of these 4 procedures together. And you are more than welcome to discuss with us vividly during these procedures. We have a very nice panel, a large panel of 10 people. We're not going to introduce them individually to you. And without further ado, I hand over to Mariana. She's going to introduce the first case presenter.
Thank you, and thank you also to Abbott for setting up this beautiful symposium, and thanks for being here. Join us if you want to join a real case discussion involving an advanced heart team to participate actively in the discussion. So this symposium is supposed to be very interactive. We will have controversial cases, and also join us if you want to get updated about the latest evidence regarding MitraClip, TriClip, and Tendyne. So, without further delay, I would introduce the fourth speaker. Dr. Laurent will present us the first controversial case regarding the MitraClip, the mitral regurgitation.
Thank you very much for this introduction, for the invitation. It's my great pleasure to be there and to start this last session of the day. So the case I would like to share with you today is the case of a 62-year-old man with no extra cardiovascular medical history, but a severe ischemic cardiomyopathy due to an anterior acute myocardial infarction lately managed by PCI on the LAD in 2014. This patient, thanks to an optimal medical treatment, was asymptomatic for a long period until December 2021, when he was hospitalized for heart failure. Here you can see the transthoracic echo performed after decongestion, of course. You see that the ejection fraction is severely reduced, estimated 25%, and the left ventricle is severely dilated since the end diastolic volume is calculated 165 milliliter per meter square. Obviously, you can see a significant mitral regurgitation that led to perform a transesophageal echo, which confirmed the severity of the mitral regurgitation with an effective regurgitant orifice area calculated at 40 millimeters square. The regurgitant volume was 60 milliliters. This is, of course, a secondary mitral regurgitation with a dramatic restriction of both leaflets, especially the posterior leaflet with a coaptation gap. The jet is really wide, almost from one commissure to another. And the valve area was measured at 5 centimeters per square. The posterior leaflet was 13 millimeters. If not, the renal function was preserved. The NT-proBNP was 4,500. The pulmonary pressure systolic was 48 millimeters mercury, and the wedge pressure was high, 18 millimeters mercury, with a V wave at 47 millimeters mercury. This patient had no significant stenosis on the coronary angiography. The peak of VO2 was 15 milliliter per kilograms. And in order to complete this overall assessment, we did a full body CT, extensive biological clinical assessment that found no contraindication for potential heart transplantation. So my question for the panelists and for the audience is, how would you treat this 62-year-old patient with severe ischemic cardiomyopathy and severe mitral regurgitation? Would you propose a heart transplantation, a left ventricular assistant device, probably combined with a mitral valve surgery? Would you propose a mitral valve surgery alone, a transcatheter edge-to-edge mitral valve repair, or a mitral valve replacement, or palliative management, or if you have other ideas?
Well, okay, thank you. Thank you very much. We first of all, for the polls, for the next 4 presentations, please use your app and give us an answer because we're going to analyze this after our discussion. Please be so kind and do so. And now we go to the procedural analysis. Philip, what's your thought?
Yes, thank you, George. The first thing I thought, is this a co-opt patient or is this not a co-opt patient? Yeah, so I think we have to discuss. We have good data for the co-opt, but not so good data for the not co-opt patient. And the other thing is there were guidelines a few years ago where we have this very restrictive PML is not perfectly eligible for MitraClip. And so this is what I think about this case, what we can discuss now. Yeah, so the tenting height is the problem, maybe the problem. Okay.
Okay, we can start this discussion with our art team. You want to start, Roy?
Yeah, I can start. So to me, first, I think, yes, it's a co-opt patient. Ejection fraction is about 20%. And which is important for me when I see those patients is the amount of MR. And this patient has a huge amount of MR with even a significant gap between leaflets. So even though it could be not a definite treatment, but for sure we have improvement in the clinical status, functional class. Since it's a co-opt and we have good result that with generation 4, even though we have some anatomical concerns, we can have in 90% of cases 0.1 residual MR.
But let's ask. Oh, I'm sorry. I didn't want to interrupt you.
Just want to finish that.
Yeah, sure.
It's something that is super safe and does not preclude heart transplantation or LVAD. You can reach next step in much better condition.
So, but let me ask the surgeon. I mean, it's a borderline co-opt. It's 25% ejection fraction. It's a large ventricle. We have also some surgical options on the list. What's your thought about this patient?
So, of course, we would in our heart team discussion, we would in this surgical high-risk patient, which he is, of course, because of the impaired ventricular function, we would discuss if there are durable and predictable transcatheter options. In case it would come to surgery, because this patient is quite young, I don't know how his clinical state is, if he is very active, has an active lifestyle, then of course I would go straight forward to replacement. I wouldn't even try a repair.
Yeah, but let me ask the other surgeon. Is this a candidate for open heart surgery?
You don't like the first surgery, you change surgery. This is
Yeah. That's what cardiologists
first surgery,
always
you don't like it. Okay, second surgery. No, I mean, honestly, this is a patient I would not like to operate in principle because of the high risk of this. I don't like to do high risk surgery. I like to do low risk surgery. I'm a smart surgeon. I don't want to see patients dying. So you probably can operate, but he's a high-risk patient. Obviously, in my opinion, this patient should be considered for LVAD transplantation. So my approach would be probably to treat this patient with an edge-to-edge approach, which is what is the simplest and lowest risk option overall, but already involve the heart team, the heart failure team, because this is a patient we don't know whether this is going to be the solution, the final solution.
Indeed. What about the medical therapy? Because I mean, we are all we all agree regarding the TEER, I think, no, in a patient like this, because also the right ventricular function is quite good, because yes, there is a very low ejection fraction, but probably this patient can improve at least the symptoms after TEER. But I think that complementary approach, so the optimization of medical therapy and the TEER together can improve even more the patient outcomes, not only mortality or heart failure hospitalization, but also quality of life.
Yeah, you're right. Yeah. At this time, he's got the optimal therapy, including the FAB4, and he went into cardiovascular rehabilitation after this first myocardial infarction. So, unfortunately, there is no more room for optimization of the medical treatment at this time. The diuretics dose, he was on furosemide. He received 80 milligrams per day.
Okay.
So should we look at the polls, Mariana?
Yeah.
Could you show us the polls? There's no?
How many surgeons in the room?
Pardon me?
Okay.
This,
No ideas.
this looks not too creative.
Leave it open to discussion, I think.
So no votes or technical difficulties?
It's a gray zone.
Okay, so we
So
can.
it's a gray zone, right?
Yeah.
So would you, Nina, would it hurt to treat this patient with a MitraClip?
No, I think I agree with what has been said from an anatomical point of view. Both the ventricle is like co-opt borderline, but also the mitral, the valve is a bit unpredictable what can be the results. But considering the safety, I would certainly utilize as a bridge, see what the results are, maybe give the possibility of titrate medication if the MR reduce, and then look at the other possibilities, certainly.
And indeed, this is the result. So 75% of people think that the better option for these patients is a transcatheter edge-to-edge repair, 13% are transplantation, and 13% transcatheter mitral valve replacement, I think. Okay, so go ahead with the how do you treat this patient?
So we had a long discussion with the heart team, and we decided to register this patient in a waiting list for heart transplantation, since it's a young patient, very active. But I don't know if your country, but in France, for that kind of patient, which is not a urgent patient, no ECLS, no inotropes, this patient can wait for very, very long time. So we decided to do straight away a mitral valve repair, an edge-to-edge repair, in order to reduce the occurrence of heart failure hospitalization, maybe in order to improve his quality of life. And so, of course, the question is edge-to-edge relevant in that situation? We have some proof that it may be relevant from the Mitral Bridge Registry about specifically that kind of population of patients treated by edge-to-edge repair for severe mitral regurgitation. Those are all patients who are candidates or should be candidates for heart transplantation. And we learned from this very nice registry, first that it's a super safe procedure, as you say, since the 30-day survival is 100%. So it's a safe procedure. Second, their outcome is pretty good, since 67% of the population in this registry was free from hospitalization for heart failure and still alive at 1 year. And last but clearly not least, almost one patient out of 4 are no more indication to heart transplantation because of clinical improvement. The second question, of course, is about the feasibility of a hedge-to-hedge procedures. We have some very recent, very nice data from the Expand G4 registry that show that in this very specific, very difficult population of anatomy, that is to say, population of high risk of inadequate MR reduction, the result, thanks to the G4 MitraClip, can be very smart. So we perform an immediate edge-to-edge repair with implantation of 2 XTW in A2P2. The first grasping was pretty tricky, actually. So we had to use independent leaflet grasping for the first clip because of the coaptation gap. The second clip was very easy, and it allowed a dramatic improvement of the airway pressure from 20 to 11 millimeters mercury. We fear, we didn't discuss about it, but we fear about the immediate outcomes because of afterload mismatch. So we did a systematic ICU monitoring with an arterial monitoring of the pressure, but actually the outcome was really, really favorable. Very simple. The patient was discharged at day 3. Here is the transthoracic echo at discharge. You see the result is really good with a residual MR, just a trace. No significant stenosis, and our last follow-up is 18 months. The result is a bit worse, but since the residual MR is now mild, but the patient is now asymptomatic, the NT-proBNP is 500, and because of the clinical improvement of the patient, the heart team decided to remove this patient for the transplantation waiting list. Thank you for your audience.
Excellent. Thank you. And we have a question from the audience here. So, do you see benefit of admitting these patients few days before the procedure and perform a right heart catheterization guided and diuretics, IV diuretics, and possibly also high ABP?
Yeah, that's a very nice, very relevant question. Yes, well, it was very about the preconditioning of the patient. I mean, a precocious admission in order to make a diuretics intensive treatment in order to improve the coaptation, in order to reduce the regurgitation. It was something we used to do it a lot, especially with the first generation of the clip. Actually, with the Gen 4, we do this less frequently. It sometimes happens, but less and less. But of course, if during the procedures we see that the grasping is very, very challenging, we sometimes use that kind of AABP. We use PEP also. But thanks to the differential grasping, it's less useful. And of course, the right heart catheterization, guided diuretics can be very useful, but in that situation, in this very specific patient, I'm not sure this is very, very useful.
Yeah, I would totally agree. I mean, this is a bad ventricle, but it's not such a bad mitral regurgitation. I think you don't need this pre-treatment in this type of patient with the new devices. And keep in mind, all things you do are prone to complications. So I would be really reluctant to use an IABP in such a patient if you can just do a clip. You are dealing with vascular complications. So I would not be in favor of this type of treatment only if this is the last option situation. But we have to go to the procedural analysis again.
Yeah, but you had all points. I think so. Yeah, I found one slide where we can also show that we are at the moment very much beyond the expand the co-op trial, so that we can improve also the mitral regurgitation with this newer generation. So I think, and the other thing what I want to say is, so especially in the larger devices, there were some fear about leaflet damaging, and this is also a thing I want to show that we had no problems at the moment because of this larger device and more grippers, so that the force will be over the whole leaflet. This for discussion. Yeah, have you ever had some problems with leaflet damaging in the large devices? XTW.
Is there any experience here on the table? I mean, the numbers are very low. There are just a few systematic analysis, and I think they are between 0.4 and 2%, but 2% was a very small series, but in Expand, for example, it was 0.4%. So I think it's not a major problem. Any other thoughts?
Well, I would say, coming to this question, I think the risk of leaflet damage is a little bit more in the tricuspid, but in the mitral it's super safe. In the tricuspid, if you have large gaps, there can be a lot of tension. But yeah,
I disagree with this. I think we have done a number of tricuspid. I mean, talking to a lot of experience here with Georg, has been clipping since many years. Maybe we have some tears sometimes in the tricuspid. Usually it's because of malpractice, because we are having problems in visualization and things like that. In the mitral space, you need to be careful. And that is an important message. I mean, whenever I consent for this procedure, I say, this is a very safe procedure unless, and may happen, it's not happening every day, it happens probably 1 or twice in a year, unless you have a perforation. Because this is something that might happen for many reasons. The first one happened to me in 2010, and the lawsuit was finished last year. So it took 10 years to decide. And the point is, once this happens, it's not always because of you creating tension. In that case, for instance, the patient was hypotensive immediately after, was given some inotropic support. The pressure went to 300 immediately, and then the leaflet was ruptured. So it is something we need to know. It can happen. I think for those who know how to deal with these patients and with these therapies, we know how to avoid it. But still, it is something to bear in mind. We are playing with leaflets. We are not, we are implanting devices in the leaflets. So there is a risk. Thanks God, with experience, the risk is super low. But it's not zero.
Just a quick other comment I wanted to make. This, if the patient is going for clip and then for transplant, it's really good. I think it's a really good idea. If the patient would be not a transplant candidate due to malignancy or so, it can be an issue if you clip the mitral valve. I don't know if anybody has experience with LVAD after MitraClip. Is the gradient a problem for filling of the ventricle?
So there is a so this is an ongoing discussion. The only problem is when you create a gradient.
Yeah,
If
exactly.
there is no gradient, there is no problem. So if the patient is a LVAD candidate, be careful not to create a gradient. That's it.
I think that's an important.
Okay. I think we, Mariana, we need to move on to the next case. We're a bit behind schedule. So thank you very much. That was very instructive, very helpful. So, Martin, you are up for the second case.
Thank you for inviting me. So this one here is the case, and it's running a case of severe mitral regurg and complex anatomy. These are my conflicts of interest. It's an 85-year-old male patient who had a TAVI implantation 18 months prior to this hospitalization. Euroscore 12%, STS score 3%, with a severe mitral regurg and a gradient on the native valve is 6 to 7 millimeters of mercury with a, we call it intermediate MAC, not a severe MAC, but intermediate MAC, and moderate tricuspid regurg with a preserved ejection fraction. And this is the echo. See, quite a high-grade mitral regurg.
It's so calcifying.
This is slow-mo.
That's slow, yes. And this is the max. So we skipped the video here, and now the question is, how would you treat this patient? Surgical repair, surgical replacement, TEER, transcatheter mitral valve replacement, or medical therapy? Should we discuss first? Or?
Yeah. Philip, do you want to summarize why this case is controversial?
Yes, okay. It's an old patient, 85 years old, with a high Euroscore, and what I saw is a very, very calcified annulus, and I think this we have to discuss which chances we have to grasp if we want to do a TEER. And the other thing is, how is to the cardiac surgeons? I think it's not easy to decalcify this annulus. So the Euroscore 2 was 12%, but I think in reality it may be higher, the mortality of the operation. So this are my points on this case.
Yeah, sure. Julien, Julien, do you want to start? What do you think about this case?
But this case, in fact, it's a very difficult one because there are both a significant MR, but also a high gradient, because the gradient is not 2 or 3, it's 6 or 7. And it seems that the patient is in atrial fibrillation or very fast, so it might be the true gradient. So usually for this patient, there is one thing that is missing for an echocardiographic, is that mitral valve area.
Exactly, that's needed.
Because then we will discuss, according to the mitral valve area and according to the CT, what are the options. So I wouldn't answer yet. I would like to have the mitral valve area and the CT, and then I discuss the possibilities.
Do you know the orifice area?
I didn't.
It's probably somewhere between 2.5 and 3, or
I think so.
It's good.
Close the
Do you have CT data or a max score?
I will show some CT reconstructions later.
So how about surgery for this type of patient? 85, I mean, left ventricular ejection fraction preserved, but probably a lot of calcification, not easy to sew in.
I don't think many surgeons would decide to operate on an 85-year-old with a MAC. So I wouldn't do it. I wouldn't do it if it would be my relative.
Enjoy. It's not the first option, obviously. But we get some similar cases, and there is a solution. There are two solutions for this patient. So decalcification doesn't play any role. The calcium here is in the ventricle. You get out of the heart is a big problem. So you can either implant a balloon expandable valve and fix it somehow with some tricks, or you can go and do a implantation in the left atrium. So having a special skirt, you can implant a valve in the left atrium. Still, these are difficult procedures.
85 years if you do cardiac arrest and with a not really predictable result, I wouldn't do it.
We agree with that. We don't like to do it, but there is a technical solution.
So do we need more information, Roy, to discuss or to decide on that case?
I mean, for me, I think so. We need more information. I agree with Julian's comments. Of course, I think it's not a surgical candidate, so something less invasive should be the ideal strategy for this patient. But I mean, area plays an important role because we have some data of clipping in calcified annulus with not so bad results. So depending on that, maybe we can play with transcatheter replacement.
Yeah, but 2.5 valve area, if this is the true valve area, you are going to get too small annulus. So this is already closing the TEER.
Not even try.
Not even
doesn't make
start
sense.
thinking about it. So the next step is CT scan. CT scan is helpful for finding whether the patient is feasible with a transcatheter mitral valve replacement, or eventually also to plan a surgery, eventually.
Here's a question from the audience. How about transatrial TMVR? Is it a lower risk than stenotomy? Who can comment on this?
Transatrial TMVR means probably to implant a valve through with balloon expandable valve. I assume this is done on the Harlan machine and direct vision. We're not talking about valve in MEC at this moment, at least at this moment. I mean, this could be also an option. I dislike that option, but let's say this is still one option. And it is not a simple procedure. It's still an open heart procedure, and you need to implant some support for this valve. It takes time. You have it 85 years old and so on. So
risk of lung injury and all kinds of stuff. How about the poll, Marie?
Do you want to make a comment?
Something very important specifically in that kind of patient, 85-year-old and MAC, is the global assessment of the patient, his vitality, because we know that in every registry, after a successful treatment, whatever the treatment is, the prognosis is really low, the mortality is really high, something like 40 to 50% of mortality at 1 year, even after a successful treatment. So we have to assess very well the vitality of the patient and his global prognosis. So a geriatric assessment, for example, would be very useful.
Totally agree.
Great. So we can look at our pool, if possible. So 56% of people voted for a mitral valve replacement, transcatheter, hopefully. 33% for MTEER, 11% for surgical replacement. So how did you treat your patient, Andreas?
Well, I just give you some more analysis. We went for Tendyne screening process, and there were some discussions about the TR, the tricuspid regurg, but in the end, we came to the conclusion that that is the only option for this patient. And now, some years later, we also know that MEC is not a bad condition for the Tendyne, and it's also in the Summit trial a specific MEC cohort, and the outcomes are not too bad, I would say, compared to surgery. So this is promising, but we didn't have this data when we made the decision. And here we have now the CT scan, and what also made me a little bit against the TEER procedure in this case was the spicula of calcium pointing on the anterior leaflet, because this, I think, makes it even worse, the gradient. When you fix the spicula, then probably a greater area of the leaflet is fixed. So we assessed it, and you can also see the TAVI valve in place, and we measured the left ventricular outflow tract and where to puncture the heart, and this is the prediction. So for the implantation of the Tendyne valve, it's a team effort. It's 3 operators necessary, and coordination is key. So it's kind of tricky at the beginning to start with the program. So this is the case, and we came across the mitral valve with a balloon to ensure that there is no entanglement of the with the cords. And then this is the implantation of the valve, and I can make it a little bit faster here. So the valve is implanted and had a nice function. You see here, this is the 3D reconstruction of the echo. The valve was competent with a good gradient, and I speed up a little bit after. So it was also our first implantation. This is the patient after the implantation with the heart team. So quite a good outcome. And we now did a 3 years echo, and the patient is still fine, and the valve is still competent.
Wunderklappe. Wonderful. You did not predilate because it was not too calcified, right?
I think we did 120 with one predilatation with a 28 balloon.
You know, can I comment on this? I think it's a very important message here about Tendyne. We all wait for a Transcatheter transfemoral solution for mitral. But there is only one reason why Tendyne will not disappear, and this is exactly the case. Tendyne is probably the only device at the moment which will help us in patients with MAC. Even in patients with some degree of stenosis, it can be done with predilation. I probably doubt there will be soon any device that can be implanted transfemorally to deal with calcium. So that is a reason to become familiar with this technology, because it's going to stay. And this is, at the end, one of the main reasons to turn down patients for transcatheter edge to edge. I mean, the calcification of the valve is number one reason for us, because we treat almost everybody otherwise.
Excellent. Philippe, do you want to?
I think it's CT scan in this case is the key, yeah. And you showed perfectly that also in severe MAC patients, Tendyne may be feasible, but our hardest enemy, the LVOT obstruction, is still unsolved. Or do you have any comments on this?
If I may comment, we call it MitraClip. It's not on label, it's off label, but we use a simple surgical scissor and cut the mitral leaflet prior to Tendyne implantation if there is a small LVOT. And so far we have done 5 patients and they are all doing well without an LVOT obstruction. And we have now a multi-center study prior to publishing. It's 13 patients. But it's tricky. We have to be very careful with the scissor.
But only in patients where you have a risk of LVOT obstruction, not on a routine basis.
Yeah, we really select the patient.
Yeah. So you take a mixed scissor from minimal. Yeah, that's what we did also. Yeah.
And just want to comment. I think that even more patients will benefit from that, because there may be some degree of LVOT obstruction, even if and it's a dynamic phenomenon. So we really don't know.
So any other comments for Tendyne, for the post-treatment care? How do you treat these patients in your hospitals afterwards? Do they go to the intensive care unit or?
Yeah.
Please.
Okay. Yeah. They go intensive care units, of course, for a couple of days. Obviously, we assess the access, the apical access, make sure that there is no problems, and they discharge with the treatment with Coumadin.
Yeah, that was another question.
Yeah. Prescribed Coumadin.
Is Coumadin required, or could you also go for NOAC? What is your politics?
So we do Coumadin for lifelong. So, but we don't have data for that, of course. But what is very important, I think, is when we put the patient from the OR to intensive care unit, we don't do anything, no heparin, no Coumadin, nothing for the first, I would say, 12 to 24 hours until we are really agree there is no bleeding from the exercise.
And is the afterload mismatch a problem in this patient with MAC and preserved ejection fraction?
Sorry?
Is the afterload mismatch a problem in these patients? What do you think?
So yes, we've seen that. Yes.
Yeah.
So one thing is for those who have been involved in transfemoral transcatheter mitral valve replacement. We thought we could get rid of the 1 or 2 days in the ICU, and that was a problem. So yes, afterload mismatch is one of the problems with replacement. You should be very careful. Thanks God, these patients get a surgical incision, so they go 1 day at least in the ICU. But you should do ICU for all patients undergoing transcatheter mitral valve replacement.
I agree.
Yeah, I totally agree. Although I think the afterload mismatch is in patients with primary MR and preserved left ventricular ejection fraction not so.
You have it not so clinical relevant. I agree with you, but I'm saying overall the afterload mismatch may happen even hours after the procedure.
Yeah, and they are more fragile patients, and they don't benefit as a TAVI patient does if you resolve aortic stenosis, and therefore I totally agree they need more attention.
Just a quick comment on this. We do really, when we deliver the valve, this is a critical moment, and you should be ready to give fluid and to fill the ventricle and to give pressures in this case. And the second thing, we switch to bring the patient on a step-down unit and not to the ICU, and 2 of them required ICU the day after due to the afterload mismatch. So I would agree that ICU is a very good idea.
Yeah, and frequently the hypotensive situation after implantation is due to LVOT obstruction and dehydration, and therefore don't give inotropes, just give fluids. This is
a very important point, because it's sometimes difficult to distinguish between the two situations, LVOT obstruction and the.
Do everybody has always a pigtail catheter in the left ventricle to monitor? Yeah.
You have it.
You know, the transapical approach, nobody likes it 100%. Let's be clear here. You know, it's something that we have been abandoning for the aortic valve. For those who have done transapical cords, you know, the problem of having hypotension, because the patient, there is a bit of bleeding, so the patient becomes hypovolemic. And that is a pain in the neck when you do, for instance, neocords from the apex, because your geometry is completely messed up. Here is much easier, number one. Second, the bleeding risk is much lower because of the pad, which is put at the end of the procedure. So, thanks God, this procedure seems to be much safer in terms of the access compared to TAVR and compared to even neocords because of the device itself. But still, it is a more surgical approach than an interventional one.
Okay, thank you. Thank you very much, Martin, for this excellent case. So we have to move on. The next case presented by Rodrigo Estevez. Please, a tricuspid case.
Thank you. Thank you to Abbott for having me in this symposium. So we're going to talk about now to move to the right side and talk about a little bit tricuspid regurgitation. These are my conflict of interest. So case presentation is a 75-year-old woman with no cardiovascular risk factors. She has long-lasting atrial fibrillation, anticoagulated. 2016, due to long-term dyspnea, she was studied in our center, finding right ventricular dilation, moderate TEER and ASD at that time that was closed percutaneously. He has a prior episode of GI bleeding in 2019 without recurrence, and also hematological disease for that she received chemo and radiation therapy in the chest. Currently, she shows some signs of right ventricular failure, like leg edema and shortness of breath in class 3, and she is treated with furosemide, spironolactone, and warfarin. So now we jump into the imaging. This is our patient. TE analysis. So you see a dilated right ventricle with a huge tricuspid regurgitation. Consider torrential at this time with a vena contracta of 23 by 29 and a regurgitant orifice more than 1 centimeter square. Preserve right ventricular ejection fraction. You see this transgastric view that we are getting more and more used when we treat tricuspid valve. You see this it's multi-scallop leaflet with significant gap between those leaflets. So we have some lab analysis as well with a normal hemoglobin, normal renal function, increased total bilirubin, normal liver enzymes, and an NT-proBNP of 418. We did a right heart catheterization with systolic pressure of 49, wedge pressure 20, slightly reduced cardiac output, and PVR of 3 Woods units. So as a summary, 75-year-old lady with prior ASD closure, prior chest radiation, functional class 3, torrential TR, 3-score-6 with a predicted mortality for surgery of 22%, anatomically multi-scallop valve with huge gaps, as you see in this transgastric view, with the largest one between posterior, the P1 and septal of 1.2 centimeters. And now we can discuss how would you treat these patients. Surgical repair, replacement, go for tricuspid H2H repair. Someone can think about transcatheter annuloplasty, tricuspid transcatheter replacement, caval treatment, or just medical therapy.
Excellent. Filippo?
Wow.
Yes, I found a very nice slide. This is not very, very scientific. There is no randomized study about this, but from this slide I think we have this very, very tethered leaflets. We have the multi-scallop valve. We have the star-shaped tricuspid regurgitation. The imaging quality, I think it's quite good. Yeah, but we find here a score of more than 6, and this means the TR reduction is not to be is not the best with TEER, but we can discuss about safety, about what we can do as alternatively.
Yeah, thank you. This is a very challenging case. Wow. We have these 4 leaflets, we have a huge coaptation gap, and it's multifocal. It's not just on the anterior commissural line, so it's going to be a very challenging case for a TEER device. Julien, what's your opinion?
In fact, the patient has a high TriScore, so we won't refer this patient for surgery. We would prefer a less invasive strategy. And I think that there is an important point. What we are doing for all patients, we are treating those patients with very high doses of diuretics, because this patient has furosemide 80 milligrams. So we all agree that if possible, we would like to treat this patient. But no, if we want to treat this patient, we have to bring these patients with the smaller gap. And I think it's possible. And what we are doing currently in our center, we are sending the patient for hospitalization at home with high doses of diuretics during a long period, and then we can reassess the patient, and you could perform another at least transthoracic echo, not transesophageal, but at least transthoracic, and you will see that the gap will significantly decrease. And then at this moment, you could perform the intervention and probably to catch more tissue, more leaflets, and improving the results. But the anatomy, because the imaging quality is excellent, that is an important point for TEER. If you don't have an excellent imaging quality, you don't know what you are going to deal with, and you don't know if you are correct. So image quality is excellent, and leaflets you can see that. So I think it's a good candidate.
I was to take the point that this TE was done with the patient pre-op, was admitted before, done with.
So it is the maximum we can have.
That's sometimes we see. I mean, it was slightly worse in baseline. This is, but sometimes you admit the patient, you give.
So that was when you prepared the patient already as optimal as possible. Another discussion point would be for me, maybe also Nina, you can comment, is the vascular resistance in the pulmonary vasculature. You have 3 Wood units, which is borderline, which is close to contraindication, I would say. Is this a congenital ASD, or was this a congenital ASD patient? So what is the opinion of the panel to this issue, to this pulmonary hypertension issue?
So yeah, indeed, I think it was a very good point, because also, at least at the beginning, when they treated the ASD, they also mentioned that the right ventricle was already affected. So measuring right ventricular function is, for us, imagers in general, extremely challenging. And knowing that there is some increased resistance is also really discouraging treating this patient. And from an anatomical point of view, also the fact that as previous chest radiation, we learned from previous surgery that you can find also surprise in the tissue characterization of the leaflet. So a big gap where you will have to create tension, plus the possibility that from a torrential, maybe you have some satisfaction towards severe, but you probably don't reach moderate, will indeed discourage approaching this patient, I think, with the...
So would anybody opt for open heart surgery? I guess not. Right?
No, open heart, no. I think it's not an uncommon combination. Patients who have been treated late with ASD would develop the combination of slight pulmonary hypertension and tricuspid insufficiency. Usually they already, before the closure of the ASD, they already have tricuspid regurg. Usually the pulmonary hypertension in a patient with ASD is very rarely a contraindication for treatment. I mean, this is an important point. Unless there is another cause, we can see here there is a wedge pressure of 20, so there is somehow some increased postcapillary resistances, which may be the typical scenario of an elderly patient with AFib and FPEF and whatever.
So, and if you look at the polls, most of the audience voted for TEER, for the TEER device. I think we could agree on this. But we also have a third voting for replacement. Maybe we can discuss that for just a second. Replacement in this type of patient, pretty large right ventricle,
yep,
and pulmonary hypertension,
yes,
and then this afterload mismatch issue. So what does the panel think about this combination?
I think the people have been voting against TEER because he's a challenging patient. He's a 4-leaflet. There is a complex jet anatomy. And to be honest, we don't have that much experience with replacement at the moment. I mean, we are very conservative because we have been also finding issues with afterload mismatch in some patients. And I still believe that repair is safer than replacement overall. It's always the same story. So for those who think upfront replacement, wait a moment.
Yeah, I totally agree. So what did you do?
So let's try to find out. So how do we treat? So I have to say that we are participating in several replacement studies. So in one of the studies, we tried to include the patient, but it was not anatomically suitable. There's other thing that we have to keep in mind. So our mindset is always assess for TEER first. If we don't believe we can achieve good result, screen for replacement. But if that's not possible, go back again, look with nice eyes to the echo and try to go for H2H repair. So that's what we did. So as you see here, we're imparting first.
So let me ask you. You know before you start with the TEER procedure, is this patient eligible for a replacement? Because that would be very important.
Was not for the device we.
Okay. But in this type of patient, you would do that. That's how we do this strategy. Because if the first clip is failing, you still have a fallback option with a replacement. And if you close the door by placing one clip after the other and going into this misery, you're not going to help the patient.
So first clip, you see, we are just transgastric orientation from 2 to 8. And we move a little bit close to the commissure because we have a gap there, and we apply the first clip, gaining some tissue bridge and preparing for second clip that we implanted like parallel to the first one, just closer to the medial part, anterior to the anterior papillary muscle. We grab a nice tissue there, as you can observe in the transgastric, but we still have a gap in the posterior part that we also have to tackle. So we went with a third XT wide clip to the posterior and septal. If you look at the superior left, we take advantage of the CGA to do this treatment in this complex gap patient.
What is the gradient at this time point? If you look at the lower left, image, okay, 2.
So with the CGA, we can capture first posterior and then swing to the septal, as you see, close, create huge tension between leaflets, and what I think is an acceptable reduction, creating this triple orifice in the transgastric. So why we opt for the TEER in this case. One, because we know that we have a sustained reduction up to 2 years. We presented BRIGHT follow-up at 2 years with 73% of patients with complex anatomies, real world with TR moderate or less. And we know that we can treat, in this BRIGHT we presented last year, a broad range of anatomies with different type of annuli and different gap size with obtaining these results. And we know as well that is one of the safest procedures that we can offer to these complex and high-risk patients with data in intra-illuminate pivotal and BRIGHT with all-cause mortality 30 days, less than 1% or 1% with very few complications. So we are very happy with this case. In the follow-up, this is the discharge echo. We optimize diuretic therapy. We agree that this kind of moderate tricuspid regurgitation when we discharge a patient. And now we have 1 year follow-up, and patient is completely asymptomatic with no signs of right failure. Now is NOAC with a slightly decreased dose of furosemide. Our failure team started dapagliflozin as well and spironolactone. We have reduction in right ventricle, reduction in annular dimensions, and I think it's kind of mild to moderate, probably residual TR, and I think we did the right thing.
Thank you very much. So, Philip, do you want to summarize?
Yeah, thank you. And perfect case, perfect result. So what I thought about TEER, so afterload mismatch, we had no problems with that. Yeah, we don't know about TMVR. So what you also said is a very safe procedure. Yeah, we had nearly no side effects. And what we don't know, I think it was a patient with an oncologic problem. Yeah, we don't know about anticoagulation, endocarditis in a TMVR. So this is my trigger for discussion. Yeah, TMVR versus TEER.
Well, so who wants to start? Please.
I would like to comment on what Professor Nikinek has said, that he would be happy to have as a bailout in mind transcatheter replacement. In that case, I would say also in this high-risk patient, we could offer surgery as a bailout with a known high risk, if that would be necessary.
Congratulations, I would have done exactly the same. And I think that it is very important to mention that one very important thing after the intervention is to get the best result as possible. And procedural success is not defined by the implantation of 2 clips. Procedural success means that you have decreased TR as much as possible. And so you should frequently, especially for this kind of patient, implant several clips, 2, 3, and sometimes 4. Of course, you are looking at the gradient, but it's rare to have a stenosis. And with this zipping strategy, you can significantly decrease here as you did. And what you have shown is that you have also decreased the diuretics dose at the end at 1 year, meaning that the patient is still alive without heart failure hospitalization with decrease of the doses of diuretics. So it's a huge success.
Yeah, it's a perfect clinical result. Congratulations. How about annuloplasty? Would somebody vote for an annuloplasty device, cardioband and tricuspid?
Well, we have some experience indeed with the procedure, and well, of course, there are some anatomical characteristics that should be first considered, but I don't remember the exact measurement, but it seemed very dilated, so we have to see if it would fit the biggest band, the F band, but it could be potentially. So indeed, if we think that the main driver was the annular dilatation, it could be the approach, but according to the, of course, RCA and the other characteristic, we should screen it first.
But maybe this patient is not the ideal candidate, I mean, because it is a patient who has probably a right ventricular dilation due to the long-standing ASD. The pathology behind probably is not the ideal indication. Obviously, you can think about annuloplasty in case of failure of the clips, so as an alternative to replacing this valve afterwards. But I will not go for annuloplasty first in this particular patient.
Yeah, I mean, it's a more complex procedure. If in dry repair we had 254 minutes we all together suffered per procedure time. And it is safe, but it's not as safe as a TEER procedure. And this anatomy also looked very large, and I think the implants we have available right now would be still too small to cover a reasonable part of the annulus, from the anterior part to the coronary sinus part to the posterior part.
Can I ask a question to everybody here? So, how often you do a Clover approach, so targeting more than one line of coaptation in your practice? Because I am starting to do it more and more liberally, because I believe that if we really want to achieve the goal of reduction of TR by combination of joining leaflets and acting on the annulus, you need to act on the annulus on both anterior and posterior leaflets. So I keep thinking that even in those patients with less extensive dilation, these patients are, they can easily go and come back with bloating right ventricle. So I feel safer if I go 2 leaflets rather than 1.
Usually what we do is we analyze a little bit the anatomy of the valve. In type 1 valves, we usually try to go to anteroseptal parallel. Well, of course, you have to analyze position of the jet, but usually 2 anteroseptal clips, if you have enough tissue, can also create huge annuloplasty effect and diminish the posterior jets. In case of multiple scallop like this, and if the P1 or the biggest posterior leaflets also participating in the TR, we go for Clover.
It is a double-edged sword, I would say. I think it depends also on the residual jet. We all start in the anteroseptal commissure. I think we agree in most of the cases. There's one downside to this Clover technique. We also use this, especially if we have a residual jet on the posterior side. But if you have an already prominent lateral commissure, you're going to open up this commissure even more. If you have a clip sitting in the anterior part and one in the posterior part, then you have this jet you cannot deal with anymore afterwards. And that's why I think it is still prone on the situation. It depends on what you see in the patient. I would be reluctant to do that systematically, but in most of the patients we need it.
I have another technical question, which is, in the left side, we guide our decisions on continuous left atrial monitoring. Do you use it on the right side? I don't, because I don't know how to use it. So who is using that?
No, we don't know. We don't have data. We don't know how to interpret these measurements. So I don't know if...
Sometimes we use it. We measure every after device. We are not sure, but sometimes you see huge big wave and after procedure, smaller or more flat. I say, okay, I did it right. Probably I did good. Even though the jet is not perfectly... we think we work on that.
Julia?
Yes, just to come back to a question from Francesco. At the beginning, we were performing only anteroseptal clips, 2 clips at the anteroseptal leaflets. We had excellent results, but because they were very old lady with chronic atrial fibrillation, huge atrium, then 1 year, 2 years, 3 years later, they are coming back. The clips are perfectly implanted. The anteroseptal is perfect, but then you have a significant TR at the posterior level. So I'm moving more and more, like Francesco, towards one or 2 clips at the anteroseptal level, plus 1 clip between the posterior and the septal leaflet. And then with this, usually you will have more clipping, but you will have a result that will remain, it seems, longer. I don't know if you have the same experience.
I mean, it's eyeballing, more or less.
Yeah, of course, we have to adapt for every patient.
Don't forget the vector of dilation is towards the posterior leaflet, not towards the anterior. So it's easier to implant devices in the anteroseptal commissure, in the anteroseptal coaptation line, but in theory, the best annuloplasty-like action is when you join posterior and septal.
I think this
Excellent.
Needs to remain open. We have to move on, Mariana.
Yes, we have to move on. with the last presentation. Nina will present us the last case of tricuspid regurgitation.
Well, thank you. So we go to a case of combined and mitral and tricuspid regurgitation. These are my conflict of interest. So this was an 80-year-old woman who came to our attention because of several months of symptoms of tiredness, shortness of breath, and also mild peripheral edema, despite already some kind of diuretic therapy with thiazide diuretic because of hypertension, for which it was known since long. Together also with a permanent atrial fibrillation since many years that was indeed accepted for rate control with metoprolol and anticoagulation. At the lab test, she didn't have really special alterations or normal renal function, liver function, but of course an increase pro-BNP. And this was her transthoracic echo, which you can see already a very severe mitral regurgitation with the two eccentric jets coming from two different places. Left ventricular function was relatively preserved, bilateral dilatation, and if we look also right, we see also significant tricuspid regurgitation with some elevated pulmonary pressure and a TEER gradient of 3 meters per second, about 40 millimeter mercury. So to better characterize really these jets, this regurgitation, we perform also transesophageal echocardiography. This is first the mitral valve analysis. Here is some B-plane and 3D acquisition. So as you can see here on the left, this is a bicommissural view. So we first concentrated to this first jet coming from the posterior commissure, where you can see indeed a very severe regurgitation due to a flail, actually rupture at the level of the posterior commissure. But when focusing on the other jet, more lateral, you can see that there is a second one, also relatively eccentric, but without really a rupture or another organic apparently causes. But if we look at the 3D images, so here's from the left atrium, this is from the left ventricle, you can see indeed the rupture of the posterior commissure, but also here quite a deep indentation between P1 and P2 that was much more visible if you look from the left ventricle, as you can see here. And the color coming, of course, from both locations, so both actually responsible for the two regurgitant jets. So quite a complex anatomy, we can say is a primary MR, but with a very complex lesions. And if we look right this time, these are the classical acquisition for the TEER assessment. So here is mid-esophageal, 0 degree. You can see much more severe TEER than we would expected actually with the transthoracic echo. Here's the inflow-outflow, where you can see some redundancy of leaflet and a very important jet coming mainly from the anteroseptal, which you can see also in the corresponding log axis. This is the transgastric. We have seen very important ones, which suggests indeed that also the posterior leaflet might have indeed two scallops, but the leakage seems to come mainly from the anteroseptal commissure, and this is a very deep transgastric view just to suggest that there is some also extensive tissue at the level of the tricuspid regurgitation. So again, a severe tricuspid regurgitation that accompanies the severe primary mitral regurgitation. So here comes the question, what would you do? To help you, I just summarize also the scores, the STS, 6%, the TRI-score, if you put yes or no, congestion of the right side could be between 2 and 5. So you would maybe don't do anything in this patient, but just increase the diuretic therapy, because we did this analysis only with the therapy I showed you. You would think of surgery, combining mitral and tricuspid valve repair. You could think of treating transcatheter only the mitral valve, for example, with the TEER, or maybe already approaching both valve transcatheter with the, indeed, both mitral and tricuspid valve.
Excellent. Philip?
Yes, it seems not to be so easy to treat the mitral valve with a TEER. I think so. Primary mitral regurgitations normally can be well treated with a MitraClip, but this is the first point. I want to trigger the other thing is we have no hemodynamic information at the moment. So does it make sense also to do it combined, M-TEER and T-TEER, do it staged, or only conservative treatment of the secondary tricuspid regurgitation? So these are my questions, my points.
Nina, can I ask you some details? So first of all, I don't think it's a difficult TEER unless there is any risk of stenosis, correct? It's a commissural flail, maybe some annual dilation as well, but the main jet is this. There is a flail. I mean, we can treat the flail. And if it is a flail, then, and if the patient is operable, I would go for both, mitral and tricuspid. And I have here, Giuliani said you should not use TriScore in these combined patients because they're not being included. The TriScore has been designed for isolated TR. This is a secondary TR in the context of primary MR. So in surgery, no discussion, you need to treat both. As we go into the percutaneous field, I still believe that if you have a primary lesion with severe MR, a stepwise approach is more than acceptable. And the only area where I see combination of therapies probably is atriogenic TR and MR, because you never know whether it's MR or TR.
Yeah, but I totally agree. Can you tell us the age again of the patient? I missed
80.
it.
80.
Okay. But whether the TR improves or not after the mitral intervention does not rely on the nature of the mitral disease. It relies on the extent of the tricuspid disease. If you have torrential TR, it will stay. But here I agree with your notion. It could also improve over time. We have 30 to 40% improvement in patients after proper mitral treatment. So it's an open discussion. On the other hand, if they stay there with severe TR, that was our motivation to go into that field. They're doing worse. They're doing as worse as if you wouldn't have treated the mitral, almost.
Mainly quality of life. When you say worse, it's mainly quality of life. I mean, the data is very supportive for combined procedures in terms of improving quality of life, improving exercise tolerance in those patients who undergo both therapies. I agree with you, but still, this is a bit different case.
Yeah.
And there it's difficult because the patient is in chronic atrial fibrillation, so probably there is significant dilation of the tricuspid annulus. I didn't remember if you had the size.
Yeah, well, it was 45 actually.
So if you have 45, probably there is a mechanism to
But that was also a little bit our thinking, because she was relatively stable for many years, so probably she had an atrial TR already, we don't know. And all of a sudden, within a month, she developed symptoms, so probably the rupture of the commissure was, of course, in a second moment. So in a way, we were looking at the TR as a functional atrial TR, secondary, of course, and probably worsened by the then worsening of the mitral.
So how is the administration of the hospitals in Austria? Would they kill you if you would treat them concomitantly? What's the reimbursement situation?
That's a very good question. So first of all, I would really look at the pulmonary pressure. This could be quite high, and then a staged approach would make sense. And definitely, I don't know if I'm really allowed to say that, but it's the most cheapest way is to do it combined, because we cannot, anyhow, the hospital is not functioning by getting DRGs, so we just pay for the procedure, and we only pay one procedure and treat 2 valves. If you make a stage approach, it's double the price.
I think that a personalized approach in this case is mandatory, because it depends on the phenotype. If you have a severe pulmonary hypertension, you can expect an improvement, so you can perform a futile procedure on the tricuspid valve. On the other side, if you have an atrial disease with a biatrial enlargement, you cannot expect an improvement of the R. In that case, probably is a combined approach.
Do we have the pulse, by the way? Do we have the result of the pulse?
One comment could be that there is, even if I want to treat a tricuspid, it makes maybe sense to wait 3 months to let the pulmonary pressure go down, because then there is maybe a better perioperative phase. So So even if I'm sure to treat the tricuspid, maybe the patient benefits from a lower pulmonary pressure. I don't know.
But to take the perspective of the case presenter, of Nina, on the other hand, it's an 80 years old patient and she has to come back in the hospital. There has to be another general anesthesia. This is also an argument. I'm not sure about what's the right thing to do.
We discuss indeed many of these options. In a way, we thought that the anatomy of the tricuspid valve was less simple than we thought in terms of the scallops. There is some redundancy of the leaflet that you would not expect in this patient. And one of the limitations is that we did not perform a right catheterization, so I can disclose this already. But because from the echo there was a relatively good estimation of the gradient, which was maximum 3, and we sort of estimated that the chance for her to have indeed a very important precapillary hypertension would be very, very unlikely.
I mean, the polls are also not so clear. 50 versus 35%. So. Yep. What did you do?
This is really the clinical challenge we had. So how did we treat? Well, we indeed opt for just approaching first the mitral, so with an TEER with 2 actually XTW clips. I think we can discuss, as Professor Mazzano was saying, how complex was this anatomy. I think for experienced center, indeed, this is actually feasible. But if you look at the official criteria, this is actually a very complex mitral valve. So we decided to first approach, of course, the flail of the posterior commissure. As you can see here, we placed the first clip, this from the left atrium, from the left ventricle. So indeed, if you don't get entrapped into chorda, actually it's not so difficult to just close the commissure and grasp, in that case, the flail. But as you can see, we had a residual jet, as we were expecting from the more middle side due to this deep indentation. So here the approach was to try, yes or no, to add a second clip and where exactly as compared to the indentation. So we tried more in the middle. We tried actually several localization, and this was the one indeed leading to the lowest gradient. We had a mean gradient of 2 millimeter mercury with the good indeed results, as you can see, very a good reduction of the mitral regurg. And intra-procedurally, we looked immediately at the tricuspid regurg to see if there was a acute decrease. And well, as you can see, I think we thought that there was a slight decrease already, although still with an important regurgitation. Here, going into the deep transgastric, you can see indeed this redundancy and still some eccentric jet. But we thought indeed that we could accept this as a small reduction and to, as we said, decide to wait and monitor the patient over time. And indeed, we didn't go for surgery, although our, of course, surgeons are prone to have good candidate for mitral valve repair, which would have been good in this case. And of course, in case would have gone for surgery, the combination with tricuspid valve repair would be a good option. Although we know we have these new clinical trials that shows the fact that adding, of course, tricuspid valve repair, if the regurg is not severe, might also give increased risk for pacemaker and another complication that in this patient could be considered. But instead, for the combined versus wait-and-see strategy, as we have seen, we don't have much data. We don't know, indeed, what is the best approach. But there is some indication that, indeed, we should base mainly on the presence of the type of pulmonary hypertension, other isolated post-capillary, instead of combined pre and post. And indeed, as we mentioned already in the discussion, probably the etiology of the tricuspid regurgitation should help us in deciding whether this is more ventricular predominant or atrial predominant, could go in one or the other direction. And in this case, I think we discussed the etiology was still a little bit unclear. And probably certainly an atrial component, so we could have shown the concomitant strategy But in this case, indeed, we chose for follow-up. So at 3 months, we saw the patient already for the clinical evaluation. At 6 months, we did the echocardiographic evaluation. So clinically, she improved very much. She had no dyspnea anymore, much more energy, still the mild peripheral edema, but that was kind of chronic for her, still with the same diuretic regimen. The results of the mitral valve, as you can see, were still good with a slightly higher mean gradient of 3 millimeter mercury. And the tricuspid regurg, as you can see, was slightly reduced, but still remained significant, while the pulmonary pressure went down to a maximum TR velocity of 2.5 meters per second. And because of the clinical improvement, we decided indeed not to do anything in this patient, since that is the main goal of our therapy at the moment. And we followed up actually very recently. She had the last checkup that was 1 year after the procedure, where the results, I think, can be pretty comparable. I think this we might doubt whether to call it severe TR, but the pulmonary pressure remained more or less the same, and she was indeed clinically very well.
Excellent. Philip, do you have any additional comments?
Really nothing more to say, I think so. So it was absolutely perfect.
If I may, it's very important to understand that it is a very frequent situation to have concomitant MR and a significant TR. And if we look at the results of the EuroHeart Survey 2 registry, which is not yet published, with approximately 7,000 patients with significant left heart valve disease, patients with severe MR had at least moderate TR in more than one third. One third of patients with severe MR have also moderate or severe TR. And if we look at patients that we referred for surgery for MR, for severe MR, 95% of patients who had also severe TR were referred for a concomitant tricuspid surgery at the time of mitral valve surgery. And for patients with moderate TR, 3/4, 76% were also referred for a concomitant intervention. So meaning that for surgery, no cardiologists and cardiac surgeons are usually referring patients for both concomitant mitral and tricuspid when there is significant TR, and probably we should do the same for the transcatheter, even if I don't know what is the best solution, if we should do it concomitantly or if we can wait, because for surgery you have to do things at the same time, while for transcatheter you may allow to wait a bit.
But even for surgery, the data are very poor. I mean, I would not say we have to do this. We have to study it, because we don't know. Even for surgery, you showed this publication. This publication is not at all encouraging.
But this is not the same population.
Yeah.
Yeah. And that is trial on moderate TR prevention. So it's not this kind of patient.
Sure,
I mean, but if there was no problem in reimbursement or in cost of procedure, this probably is a good patient where you should combine, because it was atriogenic and primary together. So there was some atriogenic component on TR. So in principle, it would be nice in these atriogenic patients to think about treating both leaflets, both valves, because honestly, I don't think there is a atriogenic TR or atriogenic MR. There is atriogenic AV valve regurgitation.
And the NRIS is 45.
So any other comments?
Is there
Beautifully
a question
done, by
from
the
the audience? Did you consider Tendyne for this patient?
Well, to be honest, not, because we were kind of self-confident that we could solve it. We have indeed, in our experience, a really high failure of a Tendyne screening. So we are a bit frustrated with the idea, and we indeed thought we could solve it quite easily with the
So
clips.
TEER first, always. Okay. Thank you. Are there any other comments?
I have a provocative question. So you suggest that simultaneous treatment of both mitral and tricuspid regurgitation have economic benefits. Is that you suggest to treat tricuspid with a MitraClip in tricuspid position?
Well, the question was not I suggest, but I was asked this question. And what we do is we use the TriClip system and use a MitraClip in the mitral position and also in the tricuspid position. This is off-label, I have to say. But even if I wouldn't change the delivery system between the procedures, just go with the tricuspid system and clip both valves. I think that's okay. But typically, I don't really think about economics. I really think about the pulmonary pressure and what is best for the patient.
Sure, absolutely. Roy, any comments from your side?
No, I mean, we are not doing too much combined, but if we do it, are in these, as Prof. Maisano mentioned, those atriogenic old ladies that usually present with signs, not only left congestion, but also right congestion, and with more TR than MR. Usually you find TR5, MR3. We combine those patients. In this case, probably we just have waited because MR was so large.
So how is your practice in Bad Oeynhausen in these patients with moderate TR? Patients who are referred for mitral surgery and they do have moderate, not severe TR. Do you treat TR? Do you put a ring in if they're above 40 millimeters or?
Talking about surgery now.
Yeah.
Yes, if the MR, if the TR is moderate or higher, I would put in a ring if the annulus is above 40.
Okay.
It was suggested by a study from the CTSN as well, that moderate TR should be treated.
Yeah, but she showed the New England data just a minute ago, and she made a nice summary. Clinically, they did not benefit, but they traded it in for more pacemakers.
10% pacemaker rate is amazing. It's a lot. On the other hand, it's a low. The endpoint has been mortality, and you see already some divergency of the two groups. Maybe wait a couple of years.
We have to wait, maybe.
Yeah, maybe wait a couple of years. You see difference, and there is a big difference. The problem you open the chest once. You don't want to open the chest.
Absolutely.
Twice. That's the
what
big
was striking
bias
in the trial is that was working for the moderate MR, but not for the only dilatation. So that is mild blood dilatation. We didn't have even the effect on the progression of but moderate indeed is.
Just one more comment. If we talk about surgery in detail, these patients typically benefit from occlusion of the left atrial appendage. This is an additional benefit for risk reduction, I would say, which is not given if you have to go for transcatheter.
Excellent. Thank you, Nina. So in the last 5 minutes, we are supposed to commemorate the 20 years of TEER experience. So we will share with you our personal turning point in the MitraClip and TriClip journey. So we'll start with the first slide here. Which is mine. Okay, so when I think about the MitraClip and the TriClip journey, I think about my team, which is growed up during this last year and became extremely skilled and attractive. And the MitraClip and TriClip procedures are a typical example of how to work in team. So I thank my team.
That's mine.
Yeah.
Okay, go ahead.
Game changer. So I received this video from Cybercar, and this is the first time I see real-time reduction of MR using this device. So imagine we are back in 2008. I never saw before in my life that you can reduce MR and you can see it as it goes. As a surgeon, I've always been seeing the MR first, treat the MR, go off pump, ask for the outcome. And this was also another turning point because I was totally against using clip for FMR. At that time, it was still FMR, which I think is the best definition. And Cybele convinced me the opposite. And actually, after that, we have been starting doing this pretty liberally in Europe. Access U was 75% FMR versus 25% DMR.
What is this now?
Sabine?
So the next one is mine. So I was always thinking that edge-to-edge therapy will be replaced by other procedures which are more effective to eliminate regurgitation to zero. And this was an aha effect when I realized this is a procedure to be here to stay. Because in 2016, the numbers of MitraClip procedures in Germany exceeded isolated surgical mitral repair numbers.
I think this is mine. So for me, my turning point was, one of them was when we treated our first patient. If you can see the video loops, is 2014. First patient with acute mitral regurgitation after myocardial infarction. It was our third case in our experience at that point. And with this new procedure, we changed the life of this patient that was really in a really bad situation. So that showed me that that gift will stay, and because of the safety and the efficacy of the profile. And another turning point for me as well, and I like to thank this company that is Abbott, is the first time that I work with some partners that you create a strong team that built not only in using the device, but in amazing clinical evidence. You said when COAPT was presented with Redstone. And one important thing is that we learn through all this 20-year journey each other. We just learn from them, they learn from us, and now that's the results we have.
Wonderful. We need to be more concise. We're running out of time. Please, only 20 seconds.
So this is my turning point. I had the privilege to be in the audience in TCT in San Diego in 2018 when Greg Stone presented the now well-known results of the COAPT trial. So it was really great to assist this.
Yeah, this was my game changer. Size does matter with the Gen 4, because we saw this from Francesco. This was a completely other game. Yeah, if we have these longer arms, if we have these grippers, they are going down. We can slowly close the valve. This was close the clip. This was my game changer in the last years.
So this is a young lady. She had received 2 heart transplants due to graft failure and developed severe mitral regurg after rejection. And I put 2 clips, and she was very well afterwards. It worked well, and she was so happy that she has not to undergo a 3rd transplantation, that she got this tattoo where you see the 2 clips.
This is mine. In the turning point was when I saw the first patient, and I see many more afterwards that enter in a wheelchair in my outpatient clinic. And after the procedure, she came back walking and telling how much she enjoyed life. And then thanks to the teamwork, I believe that this is really a crucial point when you learn to work together. And we became better in our results, in the safety. And here you can see an example of efficiency when in one day, as you can see from the finger of the nurse, we did 7 procedures in one day, and the patient was awake before 4 o'clock in the afternoon.
So my turning point is depicted by this illustration showing the case, the first patient that was treated in our center for a TriClip. The patients told me first that when she was young, she had lovely legs, and that following the intervention, she regained her legs. And the second point is that because she was not able to climb the stairs, she was condemned to stay on the ground floor of her house, and that following the intervention, she now could ascend the stairs and sleep in her room.
Good.
So she was happy.
So this is
Als mir auf einmal bewusst wurde,
mine.
ich kann vollkommen durchatmen, das können Sie sich gar nicht vorstellen. Ich lag im Bett und hatte die Hände so auf der Brust. Auf einmal hob sich meine Brust, die Hände hoben sich wie Vogelflügel. Da habe ich gedacht, oh Gott, ich atme. Wie herrlich, wie herrlich.
So there's no more to say. This is a 96-year-old patient we treated with MitraClip and TriClip because she had severe disease on both sides, and she went from New York Heart 4 to 2, and she's now 98 or 99 years of age. I just met her a couple of weeks ago, and she's still up and running, and I found this very impressive. And I'm showing you this because not we are heroes, because it's such a safe procedure. It's easy to do and has a lot of efficacy, and it brings back a quality of life and maybe even life expectancy to such a patient. And therefore it is such a wonderful treatment we have in our hands for these patients. Mariana, we're all done. Thank you to the panel, to the presenters. I think this was a very interesting, very exciting session. Thank you also to the sponsor, especially to Maria, who helped us quite a bit and supported us tremendously. And this is 20 years of TEER experience, and there will be outside, there will be a celebration done by Abbott, and let's go outside.